And I congratulate NOSA for organizing this TOSA's first midterm CME, especially all the organizers, more specific Dr. Hariprasad and my friend Dr. JP. First, let me go through a couple of cases. This is a 5-year-old child who has sustained a fracture while sliding down a slider, and he has, in the AP view, it looks not that bad, but when you look at the lateral view, you see the lot of displacement. It is a type of intertrochanteric fracture. We went ahead in managing by what we're doing the internal fixation with the plate and screws. Let me take you through another case. This is a 6-year-old child on the way to school, sustained a road traffic accident. It's more of a velocity is involved, most of trauma. So you see a lot of displacement, and we see a lot in a different angles. This child again underwent a open reduction with a plate and screws, united very well. But we do see other type of children. Here you have a 14-year-old cerebral palsy child who had a femoral osteotomy, but unfortunately fell and he sustained a fracture in the close subtrochanteric area and with a lot of displacement. And we managed to treat this child in a different way by applying an external fixator. It went on to heal well, though it is not very perfect, but is quite functional. We aim at function as like any other orthopedic surgeons. Here we see a little more comminution. A child with a large butterfly fragment in the most subtrochanteric area. We went ahead and fixed this with elastic stabilizing intramedullary nails, or the Nancy nails. It looks very good. As 1 week later, we see the backing out, and these nails are they're penetrating the skin. So we have to go and salvage this by doing a secondary procedure situation by applying an external fixator. With this experience, when we had the next child, a similar road traffic accident with a lot of comminution. These are all high velocity injuries due to probably the road traffic accidents here. Again, with the multiple fragments with no cortical intact. This case, these children, very brutal to put a open reduction and internal fixation. So we had ahead, along with the tense nails, we have done a X fix to maintain the length in these children. So at 8 weeks period, the length is maintained and the fracture has healed well. So with this background of all these 5 cases, we'll go ahead and discuss how to manage this inter and subtrochanteric fractures in the children. Please understand the children fractures and the adult fractures are quite different. In adults, the fractures around this intertrochanteric and subtrochanteric area are quite common. In children, it is very rare. And here we see, as you described a subtrochanteric fracture, we call it as any fracture below about 5 centimeters below lesser trochanter is called as a subtrochanteric fracture. But we can't extend the same principle to the child's femur, because if you start putting the 5 centimeters below, it will come somewhere in the middle of the shaft. So the fracture distance should be less than 10% from the lesser trochanteric compared to the total shaft of the femur. This is because in this particular area, in that particular 10% area, the muscles deforming forces action results in causing more deformity, and it is difficult to control the reduction there. So with this background, we have various treatment modalities. We have a conservative management where we can apply immediate spica or a 90 degrees of the late spica, or we can manage with the intramedullary osteosynthesis depending on the age, a flexible nails or the rigid nails, or supplementing sometimes with the spica and the external fixators, and also sometimes the extramedullary osteosynthesis by plate and screws. So, and this treatment options always depend on the age of the child and the fracture geometry. So this makes the children fractures are quite different from the adults. So let us go for a bit of conservative management. The spica cast is usually can be immediate if it is a undisplaced fracture. A very small child, maybe less than 4 years, and where there's the trauma velocity is not a high velocity trauma. If it is a high velocity trauma in the small children, you probably initial traction in a later cast, and you should be followed with a periodic X-rays to see if there is any displacement. See, one of this particular child, seems to be, we thought it can get remodeled, and we have put them in immediate spica, and over a period of time, we see that there are different deformities, as because the proximal fragment is controlled by multiple muscles causing angulation, shortening, and some sort of external rotation. So the ideal position to is have the rule of 4, 430s, that is hip in flexion of 30 degrees, in hip in abduction 30 degrees, external rotation, and also the knee should go into the 30 degrees of knee flexion. This will be probably a correct posture in the cast. So let us go through a bit of merits and demerits in plate fixation. It is very stable, okay with comminution, but we need to do extensive soft tissues, probably second surgery to have the implant removal, and a greater risk of infection and a greater growth stimulation. But here the patient satisfaction is quite high when compared with the hip spicas and other things. In a young adolescent, we can have a rigid intramedullary nails, but definitely not through the piriformis entry because of the fear of avian. It is always through the trochanteric or the lateral entry, so in order to prevent the avian. But all these outcomes should be based, they should be studied or should be assessed for assessing a quicker healing and preventing avascular necrosis, to maintain the length, to have a early mobilization so that they don't miss the school, weight bearing and psychological results. But our criteria is other criteria which are recorded is by the acceptable radiological criteria. We should not have below 8 years. The shortening should not be more than 2 centimeters. Probably angulations and coronal 15 and sagittal 20. And in over the 8 years, we can't accept shortening of more than 1.5 centimeters, coronal in 10 and sagittal 10. I think with this I'll end this, and I thank you for all the kind attention.
Management. So I take this opportunity to request Dr. Ved Prakash to enlighten us about post-operative management.